And when we're talking about the regenerative treatment for the osteoarthritis, we have really a lot of solutions, a lot of different techniques. And really, we have to take little bit, put them in order, because it's not an easy goal to standardize all these types of treatment, because there are really a lot of them. Some of it aiming cartilage regeneration, most of them probably aiming to restore the joint homeostasis. So when we are talking about injectable treatments for the osteoarthritis, there are different possibilities coming from PRP to RPS to stem cells injection. We really have a lot of possibilities. But the first thing you have to ask yourself is that you have to define what we are going to treat, because there are different diseases, at least for my opinion, that we name osteoarthritis. So you really have to look at what is the real indication for what you're treating. And most of the time, when you're talking with a patient, you treat a very simple thing. You treat a knee pain. So before going to the intra-articular complicated or less complicated treatment, you have to ask yourself if this patient have intra-articular or extra-articular source of pain. Because most of the times, most of the patients have an extra-articular component of pain, at least in part, which can be tendinitis of pons and serenus, can be damage of collateral ligaments, it can be a nerve entrapment or vascular lymphatic problems. So you have a lot of other sources of pain. So before starting your injectable treatment, your intra-articular treatment, you have to understand what is the source of pain in this patient. Never start injection or whatever you are doing before understanding why the patient is painful, because it can be also bone marrow lesions, can be synovitis, it can be also rheumatic disease. So the first thing is to stabilize the cause of the pain of this patient. And when we are talking about the articular damage, you're talking about the cartilage defects, which is completely different from the degenerative joint. And when you're talking about cartilage defect, most of the time you're talking young, sportive patients with isolated lesions that needs probably surgical treatment to restore their cartilage. But when we are talking about the degeneration of the joint, I roughly divide it in two big types. In reality, we have much more types, but dividing the mechanical type of osteoarthritis, especially the early mechanical osteoarthritis, and more severe, more inflammatory types of osteoarthritis. When we're talking about a biological injective therapy, most of the time, I think the type of the patients you are going to treat are patients with this sort of mechanical osteoarthritis. What patient it is? It's patients normally they are middle age, sports active frequently, have multiple lesions. Most of the time they have early or a little bit less early osteoarthritis changes. And the particular thing that these patients, they are more and more and more, and most of them underwent cartilage treatment, and most of them especially underwent previous meniscal on ligament surgery, especially meniscectomies. We have done we abused of meniscectomies in the last year, and now we are paying the price. We see a lot of patients with meniscal deficiency and post-meniscectomy osteoarthritis because it's really something that we see in our practice. So let's start look on injectable therapies, what we can say about injectable therapies. So let's start with PRP. PRP, everybody knows PRP was a big gas, it was big mediatic noise in the last 10 years. It was a lot of talks about PRP, a lot of discussions of PRP. But now we have really a lot of evidence on PRP. This is the recent paper from Giuseppe Filardo that shows the meta-analysis of 34 randomized control trials which really gives you the idea of how many papers, like how many studies we have on PRP, because it's really very difficult to have any type of device in the orthopedic surgery which have more than 34 randomized double-blind controlled trials. And so in this meta-analysis, we can see if it really works, putting together all these randomized controlled trials. It's not easy because all the types of PRPs are different, and it's difficult to compare. But if you put this all together, we definitely see that PRP works better than placebo. And most of the studies against placebo are in favor on the level not only of statistical significance, but also on the level of clinically significant. Then we have also to look on the comparison with steroids. And comparing the steroids, also we can see that most of the trials showed that the patients are not only statistically but also clinically significantly better respect to the steroids, especially when you look on the duration of the drug. The PRP duration is more. Then you look on the main comparator, which is hyaluronic acid. With hyaluronic acid, it's even more difficult because it's really a lot of studies which comparing PRP and the hyaluronic acid. And at the end, most of the studies, they statistically significant or sometimes also clinically significant in favor of PRP if you look on the graph of this graph. So the only thing that have been shown very strongly that PRP have longer lasting effects, at least 1 year, more than hyaluronic acid, but very difficult thing that we don't have enough data to compare different types of PRP, which remains a difficult part when we are talking about on PRP. So what we can sum up, we have nice results of the PRP. We have a lot of evidence, and randomized controlled trials showed that at least for osteoarthritis of the knee, the results in clinical score are better respect to the comparators, respect to hyaluronic acid, steroids, and especially placebo. We have a great inter-product variability. So we really need a unique classification to bring together researchers and clinicians and to understand what type of PRP is used in reality. So we put together recently, this paper have been published in Expert Opinion in last year. We put together a big team of experts in the PRP world and try to put together a novel coding system proposal, trying to measure the affordable parameters for any research team and any clinical team. So it's really very, very, very simple coding system. So basically the first number, you show the basal concentration of the blood, the level of the concentration. Then you have a second number that shows your concentration on the PRP. Then presence or absence of the red blood cells, presence or absence of the white blood cells, the need of activation or addition of calcium. So you can see it's really very, very, very easy encoding system. And we would like all of you try to use it once you're publishing something on PRP. Talking about the evolution of the world of PRP, is really, I like to show you this type of device is not completely new, is relatively new. In some countries is already 4 years in clinical practice, for 2-3 years, some countries not. But for my opinion, it's a very interesting device. Because in the world of PRP, we had really a lot of discussion of the presence of white cells, and if the presence of white cells is beneficial for the joint or not, and so on. This device is going in the opposite direction. It's trying to concentrate white cells, but make these white cells to produce isolate anti-inflammatory cytokines and growth factor. and try to get it's called autologous protein solution, because it's a high concentration of anti-inflammatory cytokines. And we have performed several studies on one study against the saline, and now we are finishing the study against the hyaluronic acid. And we published the results up to 3 years of the study against the saline. And these results are really the results when we see the big difference against placebo, clinically statistically significant, especially for the management of pain. But we wait for PRP, even we have a tons of clinical research, but we wait still long. We have to standardize the PRP, we have to understand, especially cost-benefit analysis, because PRP is becoming a reality, it's used almost every day, and we really need more basic science to characterize it, to standardize it, and to understand the biological effect, because not all PRPs are the same, and the users have to start understanding this fact. Let's come to mesenchymal stem cells. Mesenchymal stem cells for sure is a target and a big hope for the treatment of the osteoarthritis. But it's really a dream, or it's coming the reality, because we are talking about mesenchymal stem cells for a lot of years. For example, our group, we were the early users of mesenchymal stem cells. In late 90s, we started publishing the first clinical experience for big segments of bone reconstruction in the patients with the cultured mesenchymal stem cells combined with the ceramic scaffold. And we published our experience in 2001 already, so almost 20 years ago. But what happened in the meantime? 20 years passed, and where we are? We have to distinguish what we are calling stem cells, because we have stem cells are very well defined cells from a biological point of view. So we really have to understand if the cells are real mesenchymal stem cells or they are just a concentrated tissue, because we have a possibility to have high numbers of the mesenchymal stem cells. You have to bring your bone marrow concentrate, or you have to take the fat concentrate, whatever, the tissue rich of mesenchymal stem cells. Then you have a centrifugation or filtration process, and then you have to isolate the cells and cultivate the cells in the lab. And in this case, you really have high numbers of mesenchymal stem cells. So we can't talk in reality about the mesenchymal stem cells or what we are using, because most of the time, what we are using in our lab, in our operating rooms, is minimally manipulated one-step tissue. So it's all this step is why. In reality, as I said to you, we started in late 90s, using expanded mesenchymal stem cells just in clinical practice. But after regulatory agencies come in, European agency, FDA, and all the big agency, compare the expanded cells to the drugs. So we're going inside the drug regulation, and that's brings a lot of limitations, especially in the terms of costs. And now we have really very, very few products on the market with the expanded cells. For example, for the orthopedic surgery, actually in Italy, we have no products based on the expanded cells. So what we are using in reality, what we are calling stem cells therapies. So Food and Drug Administration open this window, which exists also in Europe, which is called 510(k) exemption. And so through this window, all the minimally manipulated, so-called minimally manipulated stem cell preparation passed. So what requirements you need from these preparations? Have to be autologous. It has to be minimally manipulated. What does it mean? It means it's not going out of the operating room, and you're not adding any type of things that can manipulate the cells and can alterate the cells, and have to be substantially equivalent to the other devices. And we are talking also about the homologous use of these tissues, which is still very, very controversial. So what happened? We start talking about expanded real mesenchymal stem cells, and now we are using cells which is just a concentrates. So this is an evolution, but it's a lot of researchers that saying that probably these cells preparations can be better with respect to extended cells. Why? Because the cells are maintained inside their niches. So the stem cells are never manipulated in the lab. Arne Kaplan, who is the father, considered to be one of the fathers of mesenchymal stem cells, the person who promoted the concept of mesenchymal stem cells, just 10 years ago started saying that mesenchymal stem cells not the cells who directly differentiate in chondrocytes or directly differentiate in osteoblasts, but in reality they are regulators. So we call them medicinal signaling cells, but in reality they are drugstores. They are regulators, immunomodulators, and regulators of trophism and regeneration and homeostasis of the joint. So at the end, we are using minimally manipulated cells preparation in clinical practice, which is also strongly supported by the scientific in vitro papers that showing that minimally manipulated cells, probably they are much less, but they are better from a biological point of view. So we decided just 1 year ago to look on some preparations in clinics. This is just in clinical practice. We looked on the studies investigated bone marrow concentrate and the studies investigated SVF, which stays from stromal vascular fracture, so concentrate of adipose-derived cells. And it's not still here, we still have a lot of problems with the evidence because, as you can see, the modified Coleman score is still low, it's under 50, so it's not high-level studies, and we need high-level studies. And when we have only some consideration, we can say that bone marrow concentration are more used for implantation combined with scaffolds. For injections in osteoarthritis, stromal vascular fracture is used much more, but we have really very heterogeneous papers with different ways of injections, different therapeutic protocols with 1, 2, 3 injections, and very different way in evaluation of clinical outcomes. So we really need something stronger as an evidence. We contributed our 5 pence in this research, and so we got financing from Italian Ministry of Health to perform this study, and we decided to come back to the animal model and compare in the rabbit osteoarthritis model the microfragmented adipose tissue, isolated, enzymatically isolated stromal vascular fracture, and expanded cells in the lab. And so and also obviously control. And the results was rather surprising because we find out, but first thing was better than the control, which is just from a morphological and regeneration point of view, which is just a great thing. And the other groups were very similar, and especially microfragmented fat was give very similar regenerative results to the expanded on all the time points, which is really interested in the animal model. So we decided to come to the clinical study, which was randomized controlled trial, not blind, but randomized, against PRP, against microfragmented fat. This have been started by us, and then we moved to Milan. So it was finished by Giuseppe Filardo and Stefano Zaffannini in Rizzoli Institute. I thank them for these slides. This is very preliminary results, only on 6 months in the first patients. And you can see that till 6 months, They failed to find the difference between the injection of the fat and injection of the PRP in these patients. So we are very much looking forward on the 12 months results of the full group to see if it works really, it is really better than PRP. And when we are talking about the severe osteoarthritis, what we are talking about? And can we do something regenerative, something biologic for severe osteoarthritis? We have a lot of patients with a severe osteoarthritis. So what we can do? So now we started 6 months that we started in Humanitas, the new clinical study, using the expanded, not expanded, adipose-derived concentrate only for the patients with Kallgren-Lorentz grade 4. So the patients who are real candidates for the total knee, but for some reason they can't, for medical reasons, do a total knee, or because they are too young, or because, for example, they don't want a total knee. So our idea is to understand how this treatment, which is minimally invasive treatment, can delay the application of the total knee in this patient. So next year, I hope I will give you the results of this study. For the moment, early results are rather promising. But when we're talking about the stem cells injection, is it enough just to put the cells inside the knee, inside the joint? Or you have to put them also inside the bone, because we're still discussing if osteoarthritis is most important component is in the bone, in the joint, in the synovium, in the cartilage when it started. So it's really, bone is a really very important component in the development of osteoarthritis. So we start to think about the intralesional injection of the so-called stem cells. This approach was used really used a lot in the hip, much less used in the knee. So we looked on the approach in the hip. In the hip, we had done this meta-analysis, and you see that there's really big number of patients treated with the core decompression plus biological augmentation, which can be expanded cells or just a concentrate of bone marrow. And in the hip, they showed in different papers that the patients treated with core decompression alone had less result respect to the patient which treated with biological augmentation. We looked on this is a very recent paper published in Cartilage. When we look on the subchondral injection in the knee, which is much less respect to the hip, as I just already said, and a lot of the studies are dealing with the injection of calcium phosphate cements, which is even different story. We can also talk about this, but now we are talking about stem cells and biologics, and we find 5 papers dealing with the injection of the PRP and bone marrow concentrate in the subchondral bone. So these patients, it's a really interesting approach in these patients. And we started this clinical study, the first clinical study, with a combination of the unicompartmental osteoarthritis combined with areas bone marrow lesions, bone marrow edema. We are injecting the bone marrow concentrate inside the bone on femoral side, inside the bone on the tibia, and also intra-articularly. This is a pilot study which we just obtained and just submitted to the CYTOKINES journal. First results in these patients, and this is a follow-up up to 12 months in the first 23 patients. And you can see this, the patients have rather immediate and strong improvement, and we are rather young patients. You can see this, mean age is 56 years. Most of them have previous meningiectomies, at least half of these patients. And you can see our results are rather good. And we have 2 failures, early failures between 6 and 12 months in this patient. This is just an example. The patient's 50 years old, as ex-sportive patients with lateral meningiectomy. You can see typical case of lateral meningiectomy, almost complete removal of the lateral meniscus, and the big degeneration of the lateral compartment. He was not really able to perform any sports and suffering very much, with rather big amount of the bone edema. So we treated these patients. You can see on 6 months of follow-up on the MRI, just we see that edema has disappeared, and the patient is rather happy on 1 year of follow-up. So what we are doing now, so what else, what next? We really have to look on the diagnosis. Diagnosis is much more important respect to the type of the treatment, because we really need to have a good indication. You need correct biological product for the correct indication. This is really the key. But how you can understand it? Which is the correct patient for the correct product? So, and they have a sort of personalized treatment. So we are looking a lot now in the biomarkers that they can help us to understand, to decide a personalized and proper treatment to a patient. And also we can monitor healing response to the treatment from these patients. Now we obtain another financing from the ministry, Italian Ministry of Health, to develop this project which deals with regenerative products like bone marrow concentrate and fat concentrates, and a precision medicine. So we will do this big clinical study comparing 4 groups, so bone marrow concentrate 2 groups and 2 groups with adipose-derived cells, comparing intra-articular and also intralesional, so intraosseous injections. That's why we need so many patients. The patient will be moderate osteoarthritis from Kellgren 2 to Kellgren 3. And then these patients will be divided in responders and non-responders to the treatment. So we can ask clinical questions like, which is better, for which patient, doing proteomic analysis and trying to do a patient profiling, trying to understand which product targets which patient. And I hope we'll be able to perform this study very soon. Other things, other studies. This is also a study that we are going to start next year. This is another financing of the Ministry of Health, is to understand if microbiota can play a role in the development of osteoarthritis and can play a role, the environment of the joint can play a role for the knee infections, but also can play a role in the life of the patients. So it's also very interesting comparing also intra-articular and intestinal microbiota. So this is all another very interesting branch of research. The last thing I want to say is that when you're talking about biological products, you are surrounded by the promotional literatures, which really all around you, showing you and your patients a lot of miracles drugs. This was very interesting paper published in Arthroscopy when they just went around main orthopedic sports medicine conferences and look on the promotional literature. And they saw that 66, two-thirds of the promotional literature lacked any type of scientific data and published results in their product advertising. And they have a lot of risk of bias for potential conflicts of interest. So we think that now we are really in the dangerous phase, and this gold rush for biologic could produce dangerous effect, especially for physicians, for the patients, but also for the competent authorities, because abuse of these biological drugs can bring to the denial of the efficacy, the real efficacy by the authorities. And so probably now it's the time to redefine the rules of the game and to talk about all these things very seriously and take in consideration the products, and only the products, which have really solid scientific background of clinical and basic research under it. And for sure, next years will be dedicated to the correct understanding, as I said, and the profiling. Because the profiling of the patient and the personalized treatment is the key of our future success, of our biological and not biological treatments. Thank you very much for your attention.